And with that, I am delighted to welcome Dr. Maureen Sue to our foundation and to many of our patients and families. She spoke at our last symposium in 2019, and we so enjoyed her talk that we invited her back. So Dr. Sue today is going to speak to you about AIRE and cancer. Thank you so much, Dr. Sue.
All right, thank you so much for the invitation, and I'm happy to be back. So let me get my PowerPoint up. All right. So my name is Maureen Sue. I am a professor at UCLA. I'm actually a pediatric endocrinologist primarily, and I also run a lab that studies AIRE and APS1. And I've been at UCLA now for 3 years. I was at UNC Chapel Hill before that for 10 years as an assistant professor and an associate professor. And before that, I was at UCSF in the lab of Mark Anderson, just like Sarah currently is. And so I think this is a very tight-knit group of researchers and really appreciate being part of this fantastic research community. We also have appreciated working with Dr. Leonakis, who has also been really helpful sharing his expertise and his patient samples as well. So I think this is such a fantastic group of researchers that you have today and who are working to try to understand APS1 and come up with better treatments for it. All right, so I'm going to talk today about APS type 1 and cancer. And as you've already heard today, we know that the immune system in APS type 1 is different. Having a mutation in AIRE changes the immune system in multiple ways. On the right here is a schematic of how we think AIRE primarily works. In the thymus, AIRE normally upregulates self-antigens so that autoreactive T cells that are seeing self-antigens are deleted. But if AIRE is deficient, these self-antigens don't get produced and these autoreactive T cells don't get deleted. So you have increased numbers of self-reactive T cells. We also know that AIRE is important for the development of suppressive T cells, and these are T cells that we know actually can prevent autoimmunity. So the fewer those you have, the more likely you are to have autoimmune disease. So we also know that AIRE deficiency is associated with having fewer of these regulatory Treg cells. And as many people have already talked about today, we also know that APS1 patients have anti-cytokine antibodies, in particular type 1 interferon antibodies. And so there are many ways where the immune system in APS1 is different. And that begs the question then, how does this affect cancer? Since we know that the immune system plays a very important role in determining whether a cancer is develops and is rejected by the immune system. So in general, we think that the immune system is important in protecting against cancer. And this is a picture of a cancer cell. And you can see that there are a number of different types of immune cells that interact with the cancer cell. And we know that certain types of T cells, natural killer cells, can directly go and kill a cancer cell. And so we know that the immune system is protective against cancer because in people who have weakened immune systems and in mice that have weakened immune systems, there can be a predisposition to cancer. So in patients who've received immunosuppressive medications, for example, in transplant patients, organ transplant patients, or bone marrow transplant patients, there's an increased risk of cancer, suggesting that your immune system plays an important role in preventing the development of cancer. We know that in mice that are immunodeficient, because of genes that we've introduced, for example, that they can spontaneously develop cancer. So the corollary of that is that an activated immune system can protect against cancer. And this last point is probably best illustrated by the development of cancer treatments that activate the immune system. And this has been very effective. It was actually the basis for Jim Allison and Tasuku Honjo winning the Nobel Prize in 2008. And what they discovered is that if you use different interventions to activate the immune system, that they were very, very effective in the treatment of different cancers. And that was first seen in metastatic melanoma. Back in 2010 in the New England Journal, there was a groundbreaking report that treatment of patients who had metastatic melanoma with ipilimumab, which is a therapy that activates the immune system, could improve survival. And this was a groundbreaking finding because there was very little before this that could be used to prolong survival in metastatic melanoma. The diagnosis of metastatic melanoma was a very devastating one because very few people survived more than 5 years with it. But this moved the needle so that people were now surviving at increased rates with metastatic melanoma. So that begs the question then, what does this mean for APS type 1? So the immune system's different. It has certain aspects of it that are activating and certain aspects of it that are potentially dampening the immune response. So we know that autoimmunity and anti-cancer immunity are linked. And an example of this is with vitiligo and melanoma. So as Sarah Vasquez mentioned, autoimmune vitiligo is a disease in which the pigmentation in the skin is destroyed by an autoimmune response. Melanoma, on the other hand, is a malignant tumor of melanocytes. And in a very well-publicized study from 2006, it was shown that those who developed autoimmune vitiligo in the course of getting immunotherapy for melanoma did much better than those who didn't. So this is a graph that shows the survival of patients who have metastatic melanoma and were treated with an immunotherapy. And if the patient did not develop the vitiligo, they were unlikely to survive 80 months out from the start of treatment. But if they did develop vitiligo, almost everybody survived. So that suggested that having autoimmunity was protective in the case of metastatic melanoma. So there's also strong evidence that the immune response in autoimmune vitiligo and melanoma have common features. So the autoimmune response in melanoma involves different types of immune cells and different targets of autoimmunity that are actually shared with melanoma, where there is an anti-tumor immune response. So that's illustrated here in this diagram from a review in 2019. On the left is melanoma and on the right is vitiligo. And the types of immune cells that are important in these responses are shown below. And you can see that T cells, both CD8 and CD4 T cells, dendritic cells, B cells, natural killer cells, those are involved in both melanoma and vitiligo. So there's shared immune cell types. There's also shared antigens. So these are the proteins that are targeted by the T cells and sometimes also by the antibodies, as Sarah mentioned before, between vitiligo and melanoma. And on the left are the known vitiligo antigens that have been described. And on the right are the known melanoma antigens that have been described, and you can see that the top four, tyrosinase, TRP1, TRP2, and GP100, are shared in common between vitiligo and melanoma. And vitiligo has been associated with APS1. It's one of the clinical manifestations of APS1, so it occurs at an increased risk, suggesting that having APS1 predisposes you to having this T-cell response against melanocytes. So that made us wonder, can this autoimmune response in AIRE deficiency also be good for fighting off melanoma? And the hypothesis is shown here, where AIRE normally works to increase the expression of melanocyte antigens in your thymus, and the display of these antigens to developing T cells results in the deletion of skin-reactive T cells. And that's important for preventing vitiligo, but perhaps may decrease your ability to fight off melanoma. In the case of AIRE deficiency, then, you don't have as much of these antigens being expressed in your thymus. These reactive T cells that are normally supposed to be deleted actually can go out and escape and cause autoimmune vitiligo. But this might be a good thing for people with melanoma, because the same response perhaps can go and reject the melanoma. So we tested this in mice where we took melanoma cells and injected them into either a mouse that was wild type, meaning it didn't have a mutation in AIRE, or in mice that have this dominant mutation in AIRE, which decreases AIRE function. And we looked to see how fast the melanoma tumors grew and whether the mice were able to survive as well, and what their immune response looked like. And mice that were deficient in AIRE, either because they had a dominant mutation, which is shown here in the circles, or because they had two of the null mutations in AIRE, which is shown here as 00. They both had smaller tumors growing compared to those who did not have an AIRE mutation, suggesting that AIRE was important for AIRE deficiency is important for rejecting the tumor, and that AIRE normally prevents tumor rejection. We also looked at antibodies, which is not necessarily the way that the immune system is getting rid of the melanoma cells, but is something that gets produced as a consequence of the T cell response against the melanoma. And we could see that there was more antibodies being made against the melanoma and cells in an AIRE deficient mouse compared to a wild type, suggesting that it also has a stronger B cell response, since antibodies are made by B cells. And we also showed that the survival of AIRE deficient mice was better than those who didn't have AIRE mutations. We also looked inside the melanoma tumors themselves, and we could see that there were more T cells attacking the melanoma cells inside the tumors, suggesting a better immune response against melanoma. And when we counted the number of these T cells, which have the marker CD3 on them, we could see that there's more of them per square millimeter in the AIRE deficient mice compared to the non-AIRE deficient mice. We also looked at how the T cells were activated. As I told you earlier, we think that activating the immune response is protective in cancer. And there's two ways that we can look at that, and that's by the expression of CD44 and the low expression of CD62L. So the rectangle highlights the cells that are the activated phenotype. So the ones here are the ones that are activated, and you can see that there's more of the activated ones in the AIRE deficient mice compared to the wild type. And this is the case for both CD4 T cells and CD8 T cells, which are just two flavors of T cells. We also know that the T cells can make different kinds of cytokines like IL-2 and interferon gamma. So this is a different type of interferon from what you heard earlier today, but this is one that's very important for fighting off cancers. And we can see that in the AIRE deficient mice that they make more of the interferon gamma cytokine than those who are wild type. They also make more of the IL-2 cytokine, which is also important for revving up the immune system compared to wild type. And this is true for both CD4 and CD8 T cells. So I also want to point out that we're not the only lab that reported this. There's also papers reported that have shown that AIRE knockout mice have a better outcome than wild type mice in melanoma. And that it's not just melanoma, but there's other cancers now that have been shown to have better outcomes if AIRE deficiency was present in the mouse compared to wild type. And there's also been a link between having certain AIRE polymorphisms, and a polymorphism just means a gene change that is not necessarily associated with disease, but can alter the function of the gene itself. So the AIRE polymorphisms that decrease the function of AIRE have been linked with better outcomes with melanoma or protection from melanoma. So just to sum up then, we think that AIRE deficiency, while it promotes autoimmunity, can also promote anti-cancer immunity. But it's also important to recognize that candidiasis, which is one of the major clinical findings in APS1, has also been linked to cancer. And Candida albicans has been linked to cancer through potentially multiple different mechanisms. And one is by the production of carcinogens. And there's some evidence that acetaldehyde is produced by Candida, and that can be a carcinogenic factor. Additionally, having inflammation that's associated with Candida can also, sorry, I said that wrong. So having inflammation can also predispose to having a Candida infection, which is related to, I think, some of Dr. Leonakis's recent work. This may be due to the autoimmunity that can damage some of the oral mucosa. And additionally, Candida albicans itself can induce inflammation that can promote cancer. And even back in 1863, a very famous physician, Dr. Virchow, noted that cancers are seen at sites of inflammation. This is a schematic of how chronic inflammation and chronic infection can potentially predispose to cancer. Immune cells can make cytokines and chemokines that can cause some inflammation. The infection can cause inflammation. This damages cell. There's some DNA damage. There's some stimulation of growth, and that can all predispose to cancer cells. And indeed, in APS1 patients, there have been reports of oral, esophageal, and GI cancers. This is a report from 2016 of 4 patients who had oral squamous carcinomas, adenocarcinomas, and these were associated with APS1 as well as candidiasis. And more recently, in 2018, there's reports of tongue cancers in APS1, and what I've highlighted here is that each of these patients had a history of chronic mucocutaneous candidiasis. So the implication is that the risk of oral esophageal GI cancers is higher in APS1, potentially secondary to candidiasis. So surveillance is very, very important. Prevention by treating the candidiasis aggressively. And then smoking is known to be a risk factor for these cancers. And so some of these patients had a history of smoking as well as alcohol use, and both of those are known risk factors. So avoiding additional risk factors that may increase the risk of cancer. All right, so just to conclude then, we think that AIRE mutations on their own are actually protective against cancer. They can enhance the anti-cancer immunity. However, to be also cognizant that APS1 is associated with oral esophageal GI cancers, most likely related to Candida, and the prevention is the key. All right, so that is all I have, and I am happy to take any questions.
Thank you so much, Dr. Sue, for your presentation. This is such interesting work. I have an initial question about the surveillance you mentioned. When you talk about surveillance for oral and GI cancers, what kind of surveillance would you be recommending for patients with APS type 1?
Right. No, that's a great question. So I think usually when you have your yearly dental checkups, your dentist should be looking closely inside your mouth for signs of cancer. But I think the really important thing for APS1 is that if candidiasis is present, that it is treated. And that would probably be the best preventative thing for these cancers.
And we have heard that sometimes you actually can't see the candidiasis. And so that becomes difficult when you're trying to figure out what's causing problems in your GI tract, for example, or in having it treated. So what would you do in that instance where you suspect that there might be Candida, but we don't know?
Yeah, that's always, I think that's been a clinically really difficult question, is that we know that there are some infections where we can't see it visually, and is there something else we can do? I don't know if Dr. Leonakis has any experience with what else might be a way of looking for subclinical candidiasis, but I'm not aware of an effective way of trying to find candidiasis when it's not visually apparent.
Okay, thank you. And Dr. Leonakis, maybe if you can add something in the chat, that would be great when you have a moment. We have another question from Todd Tellerico, who admits it's a bit off topic, but he'd appreciate your thoughts. There have been concerns about long-term use of parathyroid hormone and cancer commentary on some of the PIs for existing products. Since these products are used in replacement therapies, do you think there is added risk here?
Yeah, no, that's a great question. So there is a black box warning on PTH in pediatrics for cancer, and so that's something that we're all very aware of. I think that they were all done in animal models. The evidence in humans is not very strong that there's any increased risk, but I think there needs to be more data for us to be completely sure that there is not an increased risk. The benefits and the risks of using PTH, recombinant PTH, have to be carefully considered in patients. I think in many patients with APS1, the benefits outweigh the risks for sure. So it's, I think it's a case-by-case basis, but it's, yeah, it is definitely something that all of us are very much aware of and interested in learning more about.
Thank you. Dana Orange has a question. Do you think that there might be other scenarios besides cancer that AIRE knockout mice or APS type 1 patients might have enhanced T cell immunity for example, any infections?
Yeah, that's a really good question. We are interested in studying that question. You know, I think there are multiple aspects of the APS1 immune system that could suggest that one might have a better response in certain conditions. And there's also aspects of the APS1 immune response that suggest that perhaps it would be inhibited. So being able to tease those apart and know which ones you know, are enhanced and which ones are suppressed would be really important. So yeah, that's a very good question.
Thank you. And Dr. Leonakis has responded. He said, as Maureen states, routine oral evaluation by dental colleagues is key and can help detect even subclinical, not too obvious Candida infections. So go to your dentist and ask them, ask them about Candida. Dr. Anderson has added a question here. I was wondering if you could comment on how we can translate your work on cancer to the clinic with drugs like denosumab and anti-RANK-L. This would never have been possible without your insights.
So thank you, Dr. Anderson, for that question. So we have worked with Dr. Anderson recently, building on his observation that anti-RANK ligand can transiently deplete AIRE-positive cells in the thymus to create a APS1-like state in patients who don't have AIRE mutations. And that by doing that, we can allow some T cells that are reactive against cancer to escape negative selection. And that combining anti-RANK ligand with some of the known immunotherapies has given us additive effects in treating cancer. So that's one of the things that we're currently trialing in clinical trials for people with melanoma. And as Dr. Anderson said, it's something that we would not have been able to come up with had we not had these insights from AIRE patients. So it's one way that the research we've been doing with APS1 has benefited society as a whole in terms of new treatments for cancer. So I think that's, yeah, that's certainly something that we've gotten very interested in pursuing because there are definitely things learned from studying AIRE deficiency that have been very beneficial.
That's really exciting.
Yeah.
In addition to melanoma, are there other cancers that people with APS type 1 might be at less risk of developing?
Yeah, so I think there's been papers from a group in Japan that have shown that having less AIRE is protective against non-melanoma cancers as well. And I had mentioned ipilimumab, which is one of the checkpoint inhibitors that have become very widely used in cancer. Those have now been used in multiple different cancer types. And so I think it's very likely that anti-RANK ligand will have additive effects with checkpoint inhibitors in multiple different cancer types. I think the broad range of autoimmune manifestations that we see in APS1 also suggests that that blocking AIRE function transiently will be helpful for multiple different cancer types.
Thank you. Here's an important question. What are the signs of cancer in the mouth? This is a good question for our patients to know.
Did you say in a mouse?
In the mouth, yeah.
In the mouth. Okay.
Yes, yeah, oral, yeah.
Yeah, so those are things that your dentist, I think, are trained to look for. If you notice any growths, it's probably a great idea to talk to your doctor or dentist about it and have them take a look. But anything new, anything unusual that you haven't seen before is probably worth a mention sooner rather than later with somebody who's used to looking for them.
Thank you. And I had a question. I'm so interested in the ability of, research on AIRE and connections with PS1 to support the cancer community, more broadly. And I can see that you're already making those connections. I'm wondering, as a patient foundation, how we could connect with the patient cancer community to try and work together towards some new treatments. And if you had any suggestions on how we could do that.
Yeah, I think we're always looking for these across field synergies,
Yeah,
because that's how breakthroughs are made, right? One of the things that we've become very interested in as well is that people who get treated with checkpoint inhibitors develop autoimmunity as a secondary outcome. And a lot of the times there's the same tissues as what we see in APS1. And so we're trying to learn more about how to predict who will be developing autoimmunity in the setting of checkpoint inhibitors, and what similarities and differences that has with the autoimmunity that's seen with APS1, and potentially what are things that we can separate from the anti-cancer response, and what things are always linked. So it's kind of come back full circle, where we studied APS1, that led us to cancer, and now the cancer treatments are leading us back to autoimmunity and trying to understand APS1 through that lens as well. So yeah, so I think people in the research world are definitely interested in understanding more about how cancer immunity and autoimmunity are linked. How to make those connections, I think many of the researchers who are in the field, I think, have seen the parallels, and I think those links are definitely starting to build.
that's great. That's great to hear. I mean, we're so interested in what our relatively small disease or rare disease can do to improve knowledge more generally about illness.
Right. I mean, in a lot of ways, just like the observation that type 1 interferon antibodies, which were first seen in autoimmune diseases, right, had broader implications for COVID in general, right? I think in the same way, I think we're also seeing that there's implications for cancer patients as well.
Well, thank you so much. I think that is all of the questions we have from the group. So Dr. Su, thank you so much for your excellent presentation. We really appreciate your insights and all of the work you're doing, and also your participation on our advisory board. We are a little bit ahead of schedule, but I think that's great. It will give us a bit more time in the breakout groups. So I would love to spend a minute to thank all of our presenters today, to thank Paul Bastard, Dr. Mihalis Leonakis, Sarah Vasquez, and Dr. Maureen Su. If we were in person, we would be giving you a roaring round of applause. We're so grateful, but I hope that you hear it from all over the world as we listen to you today. Thank you for taking your time on a Saturday, no less, to share your work with us. I also wanted to thank Siyu Guo, who is acting as the official rapporteur for this event, and she will be writing up a report on the symposium that we will be able to provide to everyone. So thank you so much, Siyu.